Okay, let's dive into this. Imagine dedicating years, maybe decades, to mastering a skill, a really vital, life-saving skill, becoming a doctor, a nurse, maybe a pharmacist or a physiotherapist.
Right.
You're desperately needed in your home country, Ethiopia in this case.
Right.
But despite all that expertise, the critical work you do, you find yourself struggling to afford basic things like food, housing, even getting around. It must feel like your value is just evaporating.
That stark reality is exactly what we're digging into today based on the sources you've shared with us. We've got reports, articles, some research papers, all centering on this really critical issue for Ethiopia.
Right. So our mission with this deep dive is to get quickly and thoroughly informed on this whole challenging landscape of healthcare professional compensation there.
Exactly. We want to unpack what these sources actually reveal about how these essential workers are paid, how that compares, regionally and globally.
And why? Why is this happening? And what are the consequences? The really significant consequences for the health system and, well, the whole country.
And it's clear right from the start, the core problem jumping out from these sources is the alarmingly low compensation. It puts Ethiopian healthcare professionals among the lowest paid globally and even across Africa.
And it's not just that the numbers are low initially, is it? The sources talk about this really tough dynamic between what nominal and real income.
Precisely. If you only look at the salary figures in Ethiopian birr, the local currency, they've actually gone up over time, sometimes quite significantly on paper.
But that's the illusion you're saying.
That's the illusion. The crucial thing the sources hammer home is how the real income, the actual purchasing power, has just drastically eroded.
And the culprits are?
Well, the sources point squarely at two things: persistent double-digit inflation and severe devaluation of the birr against major currencies like the US dollar.
Okay, and this is where one of the examples you shared really hits home, I think. There's this detail about a consultant physician, someone with nearly 2 decades of experience, subspecialty training.
Yeah, a very senior person. Their nominal salary in birr saw this massive increase, almost 25-fold apparently, from about 2,400 birr back in 2008 to over 21,000 birr projected for 2025.
Which on paper sounds great, right? Like progress?
Looks like it. But the real story, the punchline, comes when you convert that into US dollars over the same period. The exchange rate just plummeted. Went from around 8.7 birr to the dollar to a staggering 124 birr to the dollar.
Wow.
So this physician's real income, in dollar terms, actually declined by over 80%. It dropped from about $254 a month down to just $173 a month in 2025.
Over 80% drop in real terms. And the source points out something else quite striking.
Yeah, that 2025 real income for this highly experienced consultant, it's roughly what a junior doctor earned 2 decades ago.
That just raises such fundamental questions about how value is measured and how it's being eroded over time.
Absolutely. It's not just about the starting wage being low. It's that these wider economic forces are constantly undermining the value of their work, their experience, their training.
And this hits their purchasing power directly. Makes basic things, housing, food, fuel, transport, harder and harder to afford.
Leading to, as the sources describe, profound financial distress and this pervasive sense of just being undervalued, deeply undervalued.
So let's dig into the specifics then. What do the sources actually say about the general salary landscape in Ethiopia? How does it break down for different health jobs?
Well, the overall context isn't great, as you'd expect from that example. The average monthly salary across all sectors in Ethiopia is cited around 7,052 birr. Using the exchange rate provided in the source for May 2025, about 135.4 birr to the dollar. That comes out to only about $55 a month.
$55, average, across all jobs.
Yeah, the median's slightly lower, and specifically for the health industry, the average is reported around 6,100 birr, which is roughly $45 a month.
$45 a month for health workers on average. That's incredibly low, especially for jobs needing so much training and skill.
Yeah.
Can we break that down more? What about doctors, nurses, allied health?
Sure. The sources give several figures, and there's sometimes a bit of variation, maybe depending on the specific report or survey method. For physicians, the starting point looks exceptionally low.
How low are we talking?
Some reports suggest junior doctors might earn as little as 4,000 to 5,000 birr. That translates to only about $30 to $37 per month.
$30 a month. Wow.
And even that experienced consultant we talked about, they're only projected to reach about $173 monthly. It's striking when you look back, as the sources do. A medical intern back in 2004-05 apparently earned around $100, and a GP in a rural hospital maybe $169 plus allowances. It just starkly shows that real value decline.
Yeah, earning less in real terms now than a junior doctor did 20 years ago. What about nurses?
One report specifically mentions nurses earning around $50 per month, and that overall health industry average of $45 probably captures many nursing staff too, reinforcing that very low level.
And the allied health professionals.
Yeah.
You know, the lab techs, physios, pharmacists, absolutely crucial people.
They are crucial. The sources list some examples. A medical records clerk is cited around 4,182 birr, which is about 31 USD per month.
Okay.
Physiotherapists show a range, 3,397 to 9,427 birr gross. That's roughly $25 to $70 USD. It's worth noting, though, some sources mention potentially higher net figures for some allied health roles, sometimes getting into the 121 to 267 USD range.
Right, so that could reflect maybe private sector work or different ways of calculating take-home pay, but the public sector base seems extremely low.
Profoundly low in real terms, yes. Medical lab technicians are cited between roughly 3,900 and 8,900 birr gross, about 28 to 66 USD. Radiographers maybe 4,350 to 10,300 birr gross, so 32 to 76 USD.
And a pharmacist.
Pharmacists reportedly take home around 20,000 birr, which is about 148 USD. Again, with some hints in the data of potentially higher net figures possible, maybe in that 121 to 267 range we thought for physios, perhaps reflecting different roles or sectors.
It's still a very challenging picture, even with those potential variations. Now, within Ethiopia itself, do the sources talk about differences, like based on experience or where you work?
They do show internal pay differences, yes. Things like education level, years of experience, getting a specialization. These do lead to higher nominal salaries, higher numbers in birr.
But as we saw with the consultant example, that doesn't necessarily mean much more real benefit.
Exactly. The real terms gain is often minimal due to inflation and devaluation. And the sources point to something really telling. A very low return on education in the health industry, cited at just 16%. That's a weak financial incentive to go through years of extra training or specialization.
That makes total sense. Why invest all that time and effort if the financial reward at the end is so eroded?
Precisely. There are also differences mentioned between public and private sectors. Private often pays more, though access is limited. And interestingly, rural postings nominally pay more than urban ones.
That's usually an incentive, right? To get people to work in underserved areas.
It's intended as one. But the source material indicates that even with that higher nominal pay, public sector physicians, for example, still struggle financially in rural areas. Sometimes they have to supplement their income with private practice on the side, if possible.
Which leads to a really important point the sources make. Why isn't that higher nominal rural pay enough?
Because compensation isn't just the number on the paycheck. It's about real purchasing power. It's about quality of life, the professional environment. The sources cite studies showing health workers need really substantial real increases, like 245% for doctors, 284% for nurses, just to persuade 80% of them to take a rural post instead.
Wow, that's huge. So what else matters besides the cash?
Crucial non-monetary factors come up again and again. Things like decent quality housing, good facilities to actually work in, supportive management, and importantly, opportunities for continuing education and professional development. It's the whole package.
Right, the whole package. Okay, let's zoom out now. You mentioned benchmarking earlier. How do these Ethiopian figures stack up on a global scale, and then maybe regionally, across Africa?
Globally, the comparison is stark, really stark. The sources often use the U.S. as a primary example. You're looking at an Ethiopian general physician earning perhaps, $360 to $444 a year?
A year.
Compared to a U.S. physician making over $239,000 a year.
That's not just a large difference. It's orders of magnitude. It's a completely different financial reality.
It absolutely is. Same story for nurses. Ethiopian registered nurses may be around $600 a year versus U.S. RNs earning $93,600 a year. And similar massive gaps exist for the allied health roles. Physios, lab techs, pharmacists, compared to their U.S. counterparts.
And this massive gap, the sources say, creates a powerful economic incentive for people to leave. The brain drain.
A powerful, undeniable incentive. It's framed as a key driver of immigration, the brain drain.
And you mentioned Ethiopia seems to be an outlier. While other countries might have faced inflation, Ethiopia's real wage decline is persistent.
That's what the sources suggest. While some countries saw inflation bite into wages recently, global real wage growth has generally been positive, according to bodies like the ILO and OECD. Ethiopia's consistent decline in real wages for these professionals makes it stand out in a negative way. It's not just a temporary blip.
So not just lagging behind, but actively falling further behind in real terms. How does it look compared to neighbors and other countries within Africa?
Regionally, the gaps might be slightly less astronomical than the U.S. comparison, obviously, but the picture is still very clear. Ethiopia's average monthly salary, around $165 cross professions, is significantly lower than many African peers.
Who are some of the higher-paying countries mentioned in the region or continent?
Kenya and South Africa are highlighted as having much higher compensation levels. Specialists in Kenya, the sources say, can earn between $1,500 and $3,000 a month.
Okay, still a huge difference.
Huge! In South Africa, specialists are often cited in the $4,000 to $6,000 range per month. General practitioners there might be around $2,300 to $2,750, and nurses around $1,485 monthly.
Those are vastly higher than the Ethiopian figures we discussed, like 10 to 30 times higher or more.
They really are. The sources also give some context for other East African nations. Tanzania shows ranges for physios, $160 to $607 nails, nurses, $190 to $671, lab techs, $126 to $607 times, though there's a note that sometimes unusually high doctor-nurse figures might reflect expat salaries, so you have to be a bit careful there.
Okay.
Uganda shows GPs around $525, physios maybe $286 to $742, but it also shows some very low figures for enrolled nurses, $19, and registered nurses, $40, suggesting internal disparities there too. Rwanda, despite having retention efforts, reportedly still has nurses earning maybe $92 to $154 and physios $98 to $498, with low salaries persisting.
So while salary challenges clearly exist elsewhere in the region, Ethiopia seems to be consistently near the bottom of the scale.
That's the critical takeaway from the benchmarking, yes. Even compared to places like Nigeria, where the health medical average is cited around $143 and nurses maybe $189, or Egypt, with doctors around $320 to $640 and nurses $163. Ethiopia's figures are often at or near the bottom for similar roles.
Which puts it at a severe disadvantage regionally for keeping its own skilled health workforce.
There's severe disadvantage, exactly.
Okay, so we've got a really clear picture now of that the pay is low and how low it is compared to others. Now let's really try to unpack the why. What are the core driving factors behind this situation, according to the sources you shared with us?
Well, the sources point to a really complex mix of factors. It starts, perhaps surprisingly, with macroeconomic policy. There's mention of an intentional government policy, as described in the sources, to set low salaries.
Oh, salaries. Intentionally. To attract foreign investors. Is that the idea presented?
Yes, that's precisely how it's framed in one of the key sources. It calls this strategy exploitative, arguing it prioritizes attracting external investment over safeguarding the welfare of the domestic workforce, particularly these essential health professionals.
That's a really strong assessment coming through in the source material.
It is. And then compounding this policy are those severe impacts of inflation and devaluation we already touched on. Salaries just aren't indexed. They don't keep pace with the rising cost of living.
So even if there are nominal increases, they get wiped out.
Wiped out. The sources mention public spending cuts in several African countries, Ethiopia included, contributing to incomes falling significantly, maybe up to 50% over 5 years in some cases. And that leads to that staggering statistic cited, 97% of surveyed health workers saying they are unable to cover basic needs like food and rent just using their monthly wages.
97%. That number alone just speaks volumes about the level of financial distress. It's almost everyone.
It truly does. And, while Ethiopia, say, the U.S., one source cites it as 69% lower, the average salaries we discussed, $55 to $165 a month, are still profoundly insufficient.
Because the estimated cost of living is much higher than that.
Yeah. Yes. One estimate puts the cost of living per person around $675 a month. So even a lower cost of living doesn't help when wages are just fundamentally too low to live on. Things might be cheaper, but they're still completely out of reach on those salaries.
Precisely. Then there are the systemic issues within the health sector itself.
Right. The sources highlight this major disconnect between professional growth and pay. That consultant physician example illustrates it perfectly, decades of experience ending up with real income equivalent to a junior role from 20 years back. And that low 16% return on education? It's a clear disincentive for people to pursue advanced training or specialization within the country. Why bother?
And national spending priorities seem to be part of this picture, too.
Absolutely. Ethiopia's health expenditures reported at only 1.7% of GDP. That's well below the WHO's recommendation of 5%.
And the sources contrast this
With disproportionate military spending. One source cites it as being more than 20 times the average doctor's salary. This allocation of national resources is presented as a direct factor contributing to the low salary and poor conditions in the health sector.
And it sounds like there's a perception, at least in the sources, of a lack of responsiveness from the government on these issues.
Yes. The sources mention instances like the health minister reportedly avoiding demands for salary adjustments, even when there were pre-strike demonstrations. There's also uncertainty noted around a new health insurance proclamation meant for professionals. It apparently exists, but needs proper budgeting and action to actually mean something.
So this perceived inaction sends a signal.
It signals to the healthcare workforce, according to the sources, that their really urgent concerns aren't being adequately prioritized, which connects back to the broader context the sources emphasize: governance and stability.
How so? How do they link governance to pay?
They tie the crisis very deeply to issues of governance, corruption, and political instability. Health professionals are framed quite starkly as casualties of a political regime indifferent to their welfare.
That's strong language.
It is. In conflict-affected regions, the sources describe workers facing not just underpayment, but extreme burnout and even direct threats, including military violence. There are reports of politicization and weaponization of ethnicity, turning hospitals into unsafe zones, making healthcare workers targets.
That goes way beyond pay.
Yeah.
That's safety, psychology, ethics.
Exactly. It impacts physical safety, mental well-being, their ability to uphold ethical duties. Working in environments marked by trauma and instability naturally pushes people to seek safer, more stable conditions elsewhere. It contributes significantly to migration pressures.
So it sounds like addressing the pay crisis requires much more than just finding more money. It needs broader systemic change.
That's a very strong theme in the sources. Comprehensive governance reforms are presented as necessary because the crisis is so deeply intertwined with these broader political and systemic failures.
And besides the big picture stuff, there are other dissatisfactions driving this.
Yes. Beyond the core financial and governance issues, non-monetary factors are also cited as critical drivers. Things like limited opportunities for training, lack of clear pathways for promotion or career advancement.
And the actual conditions they work in day to day.
A huge factor. The sources paint a picture of crumbling facilities, severe lack of essential medicines, basic equipment missing. This makes it incredibly difficult, sometimes impossible, for them to do their jobs effectively and safely.
Which leads to burnout and frustration, surely.
Absolutely. It's not just an inconvenience. It directly hinders their ability to provide care and fulfill their professional commitments. So even if pay went up tomorrow, if the hospitals lack basic supplies, the fundamental challenges would still be there.
And for those rural postings, things like housing really matter.
Critically. The sources show that incentives like quality housing and better facilities are just as important as higher nominal pay in keeping staff in rural areas. The fundamental inability of workers to meet basic needs, housing, educating their children on their salaries impacts their long-term commitment. The recurring theme is that they cannot live with dignity on current earnings.
So what does all this do to the health system in Ethiopia? What are the main ripple effects of this compensation crisis that the sources describe?
The consequences outlined are severe, and they spread widely. Maybe the most critical one is the brain drain.
We touched on that, the migration incentive.
Right. The sources state that over half, more than 50% of health professionals plan to migrate in the next couple of years, driven primarily by the search for better salaries abroad.
More than half the workforce potentially leaving, or planning to.
Yes, actively planning to leave. This loss is particularly acute among specialists, which creates critical service gaps across the country, especially in specialized care.
And that puts more pressure on those who stay.
Exactly. It overworks the remaining staff, which increases burnout, further reduces the quality of care they can provide. It's a difficult, self-perpetuating cycle. Ethiopia already has a low density of health workers compared to international recommendations, and this outward migration just makes that problem much worse.
And it's not just people leaving the country, right?
Right.
There's also an issue with where health workers are located within Ethiopia.
That's the maldistribution problem. Despite those nominal pay incentives for rural areas, severe shortages persist there. The deficit of health workers is actually much wider in rural regions compared to urban centers.
Why is that?
Partly because retaining staff in rural areas is so difficult. Some sources mention workers seeking transfers closer to urban centers, maybe seeking better facilities, amenities, or educational opportunities for their families. This puts even more strain on already struggling rural health services.
And how does all of this ultimately hit the quality of care that ordinary people in Ethiopia receive?
There's a direct and very negative impact described. With fewer skilled professionals, especially specialists, patient wait times get longer, treatment options become more limited, and the overall standard of care inevitably declines.
So people needing specialized care really suffer.
They do, because the system is struggling to hold on to the expertise needed to provide that care. And that burnout factor we keep mentioning makes things worse.
How so?
Well, demoralized, exhausted staff are simply less able to provide attentive, effective care. Plus, the lack of essential supplies means even the most dedicated professionals are hindered. They literally can't do their jobs properly sometimes. It creates a system struggling on multiple fronts: workforce, resources, and the resulting quality of care.
This must have a profound effect on the morale of the healthcare workers themselves.
Absolutely. The sources describe deep disillusionment. They emphasize that the demands for fair wages and respect aren't just, polite requests. They're described as urgent.
And that 97% figure, unable to cover basics.
It underscores the profound indignity and hardship they face. The perceived indifference from authorities, as portrayed in the sources, fosters a strong sense of abandonment. When the people tasked with caring for the nation's health feel marginalized and unheard, their motivation, their commitment, it naturally suffers.
And ultimately, does this erode public trust in the whole system?
It inevitably does, according to the analysis. A demoralized, under-resourced workforce struggling to provide adequate care leads to patient dissatisfaction, longer waits, poorer outcomes, and eventually a loss of faith in the healthcare system itself.
So this crisis isn't just financial, it's presented as something much bigger.
Yes, it's framed as a fundamental threat to the nation's health and its future, contributing to long-term consequences like potentially increased mortality rates, decreased national productivity, and a weaker overall resilience when facing health challenges.
So given how serious the situation sounds from these sources, what do they suggest could actually be done? What potential solutions or recommendations are put forward?
The recommendations that emerge from the sources are pretty clear, and they're quite comprehensive. They start, fundamentally, with the need for substantial indexed salary adjustments.
Substantial meaning?
Meaning not just small incremental bumps. The call is for significant increases designed to actually recover some of that lost real income value and critically indexed to account for future inflation and currency changes. The idea is to preserve purchasing power going forward.
So restoring lost value and building in protection against future erosion. Makes sense. What else?
Alongside pay, they call for strategic investment in the health sector itself, moving towards that WHO target of 5% of GDP being spent on health. This increased funding is seen as necessary not just for better compensation, but also for upgrading facilities, ensuring adequate supplies, funding training, and career development.
And the retention strategies need to be broader than just pay, right?
Absolutely. The sources emphasize combining competitive pay with robust non-monetary benefits. This includes things like providing quality housing, especially in those difficult-to-staff rural areas where it's a major barrier.
Okay.
Improving access to social services for health workers and their families, establishing clear pathways for career development and promotion so people see a future, and crucially, improving the overall working conditions, fixing facilities, making sure the basic supplies are there, fostering supportive management.
Basically making it possible and desirable for health professionals to actually stay, work effectively, and build a career within the Ethiopian system.
Precisely. They also highlight strengthening workforce planning, things like ensuring new graduates can actually be absorbed into the system, better tracking of where the workforce needs are greatest, and streamlining recruitment processes.
And dialogue. Accountability.
Yes, the sources underscore the need for improved policy dialogue and accountability between the government and the professional associations representing health workers. And critically, coming back to that broader theme, addressing the underlying governance issues. The sources repeatedly link this compensation crisis to wider political and systemic failures, suggesting that sustainable solutions have to tackle those root causes too.
Okay, so wrapping this up, what does this all tell us? We've taken this deep dive into the really quite dire situation of healthcare compensation in Ethiopia. Based on the sources you provided, we've seen how it compares, explored the complex reasons behind it, and understood the severe consequences.
Yeah, the sources make it abundantly clear that the situation is critical. And it's not driven by one single thing, but by this complex mix of intentional policy choices, harsh economic realities like inflation and devaluation, deep-seated systemic problems within the health sector, and these broader governance failures. The impact, as described, on the healthcare professionals themselves and ultimately on the entire population of Ethiopia is profound.
It certainly leaves you with a lot to think about.
It really does. This deep dive into the source material reveals more than just, numbers on a page. It paints a picture, doesn't it? A picture of how a nation values those who are most essential to its people's well-being and its future.
And the crisis in healthcare compensation in Ethiopia, as presented in these sources, it really suggests a profound disconnect, maybe, between the critical health needs of the population and the actual support provided to the vital workforce tasked with meeting those needs.
That seems to be the core message emerging.
So maybe the final thought to leave with you, the listener, is this. What does this crisis, as described in these sources, tell us about the true cost, the human cost, the societal cost of perhaps prioritizing other sectors or policies over public health, and the basic dignity and capacity of this vital workforce? And looking forward, what would it truly mean for Ethiopia to reverse this trend, to invest meaningfully, maybe even transformationally, in its healthcare professionals?
Those are really big questions, extending far beyond just the financial figures we've discussed. We hope this exploration of the sources you shared has been informative, and we encourage you to reflect on this material